So I'm a speech and language therapist from Manchester. I've worked with children with feeding disorders for 20 years, as of last week actually, and I've seen lots of trends come and go. So I think what we're trying to talk about is where that leaves us today and what are the treatment options, are there treatment options, and what can you expect, and what should our expectations be for feeding these children? Because they will probably all have some degree of feeding difficulty. So I'm going to talk very briefly about the beginning of the children's lives. I don't want to dwell on it too much because it's gone and it's past, but I think we do need to recognise as a professional, and we're seeing you as parents, that your child's beginning in life is very different, potentially, to a other child. So if we look at the first picture, if you're very lucky, have a very normal, relaxed birth, then nowadays, because a lot of midwifery units are pushing for breastfeeding, pushing for skin-to-skin contact, then you would hopefully be in that position of that first baby. So straight onto the skin, straight onto attempt at breastfeeding. It's all lovely, all warm, cosy. There might even be just you and the baby and dad in the room. Okay? Maybe your experience probably wasn't like that, I imagine. So you might be more like the second picture, which is a prem baby. So I'm guessing your babies maybe didn't look quite as small as that. But they maybe had to have a lot of people in the room. Your baby was taken away from you very quickly. And they had interventions such as these. So we've got some ventilation tubing, we've got feeding tubes, which will probably go orally. The ventilation's in the nose, the feeding tube goes in the mouth. That's not normal. Obviously that has to happen to keep your baby alive, but what that is going to do is that all the normal feeding reflexes that baby is born with are all going to be going into hyper mode. So the baby's getting too much stimulation around their face, around all the feeding reflexes. So the baby, they don't know what to do, and the only way they can deal with it is start to shut down those reflexes, because otherwise they're in this heightened state of stimulation. Okay, so that will often, that's going to, if you've had what we call NICU or SCABU care, then chances are you've had some of those interventions. The oral reflex is going to be dampened by anything that's around the baby's face. Your baby may be born and their muscles may be weaker, so they may be what we call hypotonics, which means a bit floppier. So the muscles generally, or maybe the specific muscles in their face. So your baby is not a lazy feeder, so we want to get that straight, first of all, because maybe, I've certainly heard people say that to me about babies, so they're not lazy. Babies are born to want to feed, but your babies are more inefficient at feeding, so feeding takes longer, and sometimes NICU don't like that because they want to get those feeds in a certain amount of time and get on to the next feed. And so there may be pressure to give up all of the feeds, potentially, I don't know. Okay, but your baby certainly is not a lazy feeder. Then, if we have to have tube feeds at that stage, then the mere presence of the tube being there, whether it's a nasogastric tube or a gastric tube, means that maybe you're more likely to have problems with reflux disease. If you have problems with gastroesophageal reflux disease, which is vomiting, then that will have impact on how the baby feeds. And the tube regimes are fairly strict, aren't they? So if anybody's had a baby who's not who breastfeeds on demand, that's what happens here, you don't breastfeed on a set time particularly. You may do when they get a bit older, but in the early days you're not in a very strict regime or a strict volume. Whereas the nasogastric tube is an artificial way of delivering a set amount of milk at set times. So things are more difficult to start with. So it's the early experiences, the reflux, you've already got problems with muscle strength and hypotonia. Tube feeding regime is artificial, and there are missed opportunities in some of those early days. Okay, that doesn't mean that you can't get them back, and we'll talk about that. But all these things just make things a little bit more difficult for your children. Just quickly to show you how it might feel for a baby who feeds with reflux, and even a baby who doesn't vomit, so they've got what we call silent reflux. So we show signs of being uncomfortable after feeds or during feeds. This is a baby, this is still from one of our clinics, so ignore that, that's pressed poppers. So there's a spoon coming in with food on, baby's mouth is full of food. As the baby's already swallowed some food, it's going back up here. That's going down the wrong way. And this bit is also going to start going down the wrong way. And the baby's still being fed. So that baby will probably feel quite panicked, as they did. So it's not a nice experience to be having symptoms of reflux and somebody to be trying to feed you. I'll just talk very quickly about the normal opportunities for feeding and how feeding develops. They are based on developmental norms. All I would like to say is, yes, probably most of your children will miss these opportunities, but that isn't the end of the world. That doesn't mean we can't get back to some of those levels. It just means we have to work harder to do it. Because if we're looking at weaning, starting to wean tastes by 5 months, as the most receptive at that age, then nowadays health visitors won't let you start weaning until 6 months anyway. Okay? And maybe your babies are in hospital for the first 6 months, I don't know, or in and out of hospital. By 5 months, we're already starting to get a dislike of new tastes, and by 6 months, the babies do develop a strong preference for different tastes. Okay? So by around the first year of age, then really we'd want it's easiest if the baby can be introduced to textures, but it's not impossible if they're not. Okay? There is a study which will say that if you don't introduce lumpy texture before 10 months, then the child is more likely to be what we say a fussy eater. So they'll have specific taste preference or texture preferences. Again, for me, that's not the end of the world. I'm sure in your situation, as long as your baby could be feeding comfortably without the use of the tube, I'm guessing, then you wouldn't really be too upset if you were on a restricted range of meals. I'm thinking most of my parents would be happy with that. So it's about gauging our expectations. And we all know children from 18 months old to 3 years who dislike anything that's new, a new colour, that looks different, that touches other food in their plate. So that's all normal behaviour for a child who's not had the start in life that your child may have had. So if we look at feeding, all babies will start off with a potential for feeding. Okay? And unfortunately in your situation what probably happens is that potential decreases and decreases, but it doesn't go away. Okay, there's more negative impacts than positive at that stage, but the feeding potential is always there. And I don't know of any robust evidence which would say that there's a critical age. So there's nothing that says if your child hasn't started feeding by 2 years, 3 years, 4 years, then just give up and forget about it. There is no evidence to support that, but I've heard that, I don't know if anybody's had things like that said to them. I've had parents who've had it said to them, but there isn't any evidence to support that. And our profession in the UK, and I could probably speak on behalf of dietitians as well, is that we would offer treatment for feeding and nutrition regardless of a child's age. So we don't have a cut-off point as well. So that's just another myth to get out the window. So our treatment aims are probably to eliminate, if we can, or certainly to reduce what we call food aversion, which can be distress on bottle feeds, it can be weaning hasn't been established because spoon feeds are refused, or it can be refusal of any food whatsoever, a refusal of being around food, being with other people who are eating, the smell of food. Okay, all those behaviours will classify as food aversion, and the aim ultimately is, but the first thing we need to do is to ideally eliminate those aversive behaviours, and certainly to reduce them. And then what that will enable us to do is the holy grail, is to wean or to reduce tube feeds. Okay, so I've put to wean or to reduce. I think a lot of parents I speak to want to get rid of the tube completely. Sometimes we need to be realistic and say, well, it might be a 50-50 balance, tube oral, or it might be 70-30, we don't know. But I think we should, as professionals, we should have that expectation that what we're doing will result in some reduction of tube feeds for a parent. Okay? So if we look at food aversion, there is a published, what we call a hierarchy of food aversive behaviours. I don't think it's particularly helpful for you as parents. All it does is enable professionals, when we're tracking a child's progress, to see how they've got with that progress. I think it's very general and it's not particularly specific enough at a certain point. So we go from point 1, the child doesn't tolerate the sight or the smell of food. Okay, well, that's our starting point. Then, point 2, they won't actually touch food. So they're happy to be in the room when you're cooking or when the feeds are being made, but they won't go anywhere near, they won't touch the food. Then we get to the stage where they'll touch it with their hand, but we won't get any transition of hand to mouth. Okay? And then we get to the stage where they'll smell the food, put it to the mouth, and we're all going, they're going to eat it, they're going to eat it, and they don't. Well, they may lick the food. That's about as far as we may get. And then suddenly we have this big jump from 4 to 5, is that they then put the food in their mouth. They might not chew it, they might spit it out. So they're not actually getting nutrition from it, but they're getting the experience and the taste orally. And then again, a big jump to 6, they eat and drink, no difficulty. So my issue probably is with the jumps between 4, 5 and 6 on the hierarchy. And I think from what I've gathered and what I've seen, because I do tend to watch your children sometimes when they're feeding at previous conferences, is that your children get to probably number 4, maybe, number 3, number 4, and we sort of get stuck there, don't we? So we're very good, I think, as in our profession, and psychologists or dietitians at doing 1 to 3, okay, which is probably the very, very severe food aversion. So we're quite good at doing that, and it's all very hands-off. We're not going to put pressure on the child, but it's what we do when we get to point 4, because we've got to move on at some point. We've got to try and move on if we can, because you do have pretend eaters, and I've seen them. So to any other person sat around, they're thinking that child's eating a packet of crisps. That's wonderful, but actually they're not eating a packet of crisps. They're playing with them, they're smelling them, they're licking them, then crumbling them, but actually, if you look at what's eaten, it's probably fairly minimal. So they're getting a good social experience, but in terms of enabling you to reduce tube feeds, it's not going to get you anywhere. So what do we do when we get to this point? Is that generally people's experience, is that we're getting stuck at this sort of level? I'm hoping that there's nobody with more severe problems. It tends to be, this is the point, the big sticking point. And this is where health professionals get a bit twitchy, because we have to start maybe challenging things a bit. So we're okay, I think, with the behavioural things. So we can do what I've called oral awareness, or oral alerting. So it's lots of activities. We've got a book called Mr. Tongue book, and we've got a My Mouth book. So it's all about learning about your mouth, learning about how it moves, how it works, being comfortable looking at your mouth, moving it, having somebody else touch you around your mouth. So again, this is all things that's fairly standard. We're comfortable doing this. It's not putting any pressure on anybody. Then we can look at what we call specific oral motor, so how the mouth moves. So I think it is worth doing some work on toothbrushing again, whether your children have difficulties getting to brush their teeth. I think last conference we had a dentist talk, didn't we, about strategies to enable you to get your child to tolerate toothbrushing. And I think it's a good starting point if your child does have some food aversions, is to work on toothbrushing as a starting point. Okay? And then we have various implements, these two at the bottom. So the one on the left-hand side is what's called a baby-safe feeder, a fresh food feeder. You get them at supermarkets. You can put some fruit or some frozen puree into that mesh, and the baby can chew in it, and nothing substantial comes out, but they're getting some chewing experience, they're getting a taste. And then chew tubes, which is the other picture. Chew tubes fine, nice. I've seen lots of children sitting chewing a chew tube, but don't eat. So they don't do any. They certainly don't do any harm. They're useful, but I don't see them as a treatment option for transitioning your child onto eating food, particularly. I think that's the problem, is that you can't live on chew tubes alone. So then get into looking at nutrition and appetite, which is where we become less comfortable as professionals. But probably the things we do, or I'd like to think that ourselves and dietitians do consider, is your feeding regime. If you're on a feeding tube, you certainly want to be on bonus feeds or have a gap in your continuous feed. Okay? That's, I think, fairly standard practice. I think most dietitians would support you, I hope, and just for the sake of your own quality of life, not to be on a 24-hour continuous feed isn't great for you as a family. And from my point of view, it's not going to stimulate appetite, and we're not going to be able to work on some of those aversive skills and actually get into nutrition. Okay, so we're all okay with that, but then we come into an area where people get more anxious about, and it's tube weaning or tube reduction. There are programs out there which are non-UK based, and there are some UK based ones which I'll talk about, where you will look at an intensive tube wean with the aim of getting a child off very quickly off tube feeds. Okay? My experience of that has been an intensive wean has only really been 10-15 years ago, where we probably didn't do it in the right way, to be honest with you. And we'll talk about what the right way might be. And so my experience years ago was that it wasn't successful. So you're looking at 5, 6, 7 day intensive wean off a tube, and the child would then eat fully orally, and everything's lovely. I didn't have any success in that situation many years ago. What I'm tending to find nowadays is that we're doing tube reduction, and it's a chip away slowly, getting those feeds down, stimulating a little bit of appetite. We're working on the food refusal, working on oral skills, and chip the feeds down again. And for some children we get there, and we get to full oral feeds. Some children we reduce the feeds, to I think a significant degree. Some children we reduce them to a lesser degree. Some children we have success with getting them to eat orally, but it's not enough to mean we can reduce the tube feeds. So there's a whole range, and in that tube reduction, there's a whole range of success, really. I think if we're going to go down that path, which I'm quite happy to do, and I'm lucky in that I have good access to dietetic colleagues, is that we need to make sure the child's ready for that. So you think back to those 6 points about food aversion. So we're saying your children, generally, we usually get to about point 4 anyway. So they need to be at that level. So they need to be happy to touch food, maybe putting it towards the mouth, licking it, smelling it, but not actually putting it inside the mouth. So we want them to be at least at that level before we look at tension reducing any tube feeds. The dietitian would want satisfactory growth, but what does that mean? I don't know. I think you have to have quite an honest discussion, I think, with your dietitian if you can. I'm guessing when your children are weighed and measured and plotted on the growth charts, they're probably plotted on the standard growth charts, which are just applied to the general population. I think it may be useful to you to have an honest discussion about what is the growth expectation for your child, and what do we expect them to take from a feeding point of view. Then feeding intake will be worked out based on their weight, as for any child. So I think there are discussions there to be had about how much feed the children are receiving. if we are going to go down to tube reduction, then we need to have some parameters. So for example, the sorts of things I might have done is, myself and the dietitian, I will negotiate, say, can we reduce the feed by 200 mils, which might be me cutting out one feed, or it might be reducing a continuous feed by a couple of hours. So can we reduce it by 200 mils? Can you give me a month? And I think that's realistic. We're not talking about a few days. Can you give me a month? And can we just keep a really close eye on weight, hydration, and just the impact on you as a family, because you don't want your child just being really grumpy and not sleeping, and see where we get to at the end of that month. And I think you need to think about that time scale. I think in the past, what we've thought is that will happen very quickly. So you take the feeds away and the appetite stimulated, the child will know to respond to those appetite stimulation by eating orally. They don't necessarily know that. Okay, so we're looking at longer time scales, maybe in the past. There are, obviously, if you're going to go down the road of tube weaning and feeding behaviours, then you really need to have psychology involved as well, which is probably more difficult service to access, I'm guessing, than speech therapy and dietitians. The psychologists themselves can't always agree about how to reduce tube feeds and how quickly to do it. So, one school of thought is that the hungry mouth learns the necessary skills very quickly. So you take the feeds away, then the child will start to eat miraculously because they need to, a survival instinct. So that's one school of thought. And the school of thought is that if you work on the oral skills of reversing or aversion before you provoke hunger, that's probably more where we sit in the UK. But we maybe need to be a bit stronger in how we approach that. And we do need to provoke hunger, but we need to do that sensibly, we need to do that realistically. If you go back to point 1, which was Marcus Wilkin, who's psychologist-based, who's a German psychologist. So he will do the intensive weans, and because he feels that the hungry mouth will eat, then he will be more assertive. So he will terminate tube feeds over, or he will reduce tube feeds dramatically over a number of 5 days to reduce hunger, and expect that the child will eat to replace the calories that are lost. Okay. In the UK, we do have, and I suspect nobody's aware, we do have weaning programmes which are for paediatrics, which are based at those 3 hospitals. These aren't within NHS services, they're commissioned services, which means they have to pay to use those services. So it's a bit of a paperwork process to get to access those services. So that's where they're based. They would offer a more intensive wean, but also the services that provide those weaning programmes will also offer some longer-term treatment and longer-term therapy for children with adverse feeding behaviours with the aim of a slower tube wean. Okay, now what I've done is, I don't particularly want to promote that company, but they are an NHS provider. I have put some leaflets out next door, which is where I'm having tea and coffee and refreshments. They are doing a really good workshop day coming up in September, October, so there's some leaflets and some flyers regarding that, which I've put next door. I've had a couple of children who are involved in the longer term weaning process with these services, and I certainly think that the reports back from parents are very positive. I've yet to have a child go through intensive weaning, so I can't report back on that as of yet. But it's a bit of a fight to get the funding, is all I'd say. So be prepared. I'm sure you are used to that in other aspects, but be prepared to you need to have the support of your professionals before you even consider going for that funding, because the timing needs to be right. Just put up, that's a picture of the My Mouth book that we talked about. We also wanted to talk a bit about speech and language and communication, so the speech bit. It's really quite hard to talk very specifically to a group like yourselves, because the difficulties that children have, I think, probably encompass pretty much everything that you could consider to be a speech, language and communication impairment. We've heard talk already about autism being prevalent, and we know that autism affects communication. But I'm guessing that your children will have problems with speech, so how the words sound. So if they're trying to make basic words, then the words won't sound like we'd expect them to sound. So that's a speech problem. The language is talking about how many words they use, if they're able to put any words together, and also how much they understand of what you are saying to them. So all those things need to be there for them to be able to understand language and to use language back to you. And then communication is how you put it all together and how you communicate with different people, which is probably where the autism bit fits in as well. So I think your children do have difficulty probably in all those areas. So it's difficult for me today really to talk specifically. But I suppose just some general pointers are with speech difficulties, obviously hearing is a major factor to consider, so make sure the child's hearing is tested correctly. If they need to have hearing aids, are they tolerating the hearing aids? Once we've got that established, don't just assume that because they can hear, that they can hear the sounds differently and correctly. So we need to look at particular sounds and just see if the child discriminates between those different sounds. So a basic test we would do is say some sounds, I don't know, pepper to a child, and we'd have pictures to symbolise those sounds, and we get them to point to the one that we've said. Because quite often children who've had hearing problems haven't got that discrimination sorted out. So that's the first port of call. The progress might be quite slow in these areas, but it's worth doing. If you can do 5-10 minutes every day, then it's not going to do any harm. But expect that you might be doing the same activities for a while. If you look at what the child understands, so what you're saying to them, what we want to do is create what we call a total communication environment. So if you went abroad and they were speaking, and obviously they're speaking different language which you don't understand, you can get by with certain help. So if somebody is pointing, gesturing, using facial expression, doing bits of mime, then there's a certain amount of information that you can get without understanding the actual words they say. So I've put some examples here. So quite an easy one to do is a story map. This is used quite routinely in nursery centres. If anybody goes to Shore Start nursery centres particularly, if the child's in specialist education, then they should really be using things like this. So rather than traditional story time, sitting reading a book to the child, we're going to involve total communication. So we're going to use objects. So this example is the caterpillar. So we've got an actual caterpillar, toy caterpillar. We've got materials that make noises, which coincide with certain points in the story. We've got pictures, and we might sign alongside that as well. So quite simple things that you can do to improve your child's understanding. Always bear in mind that what your child says, or the noises they make, the sounds they make, the words they're attempting, will be less than their understanding. Again, if you go to a foreign country, I know that I can understand a couple of words in a sentence, but what I can say in that language isn't as good as that. So it's saying for your child when they're learning language, so don't assume that because they understand 1 or 2 words, they're going to be starting to put 1 or 2 words together. So just always bear that in mind.